Morning, all. Myself, Dr. Manikandan, Assistant Professor in the Department. Today, we are going to see about acute tubular injury. So, before going to the topic, we should know some basics about the tubules. So, now I'll teach you about the basic anatomy of the renal tubules. So, the renal tubules, you all know that it extends from the Bowman's capsule and it consists of first proximal convoluted tubule, second loop of Henle, third distal convoluted tubule, and finally ends in collecting duct. These collecting duct will open up into the renal tube. So first, the proximal convoluted tube. This is located in the renal cortex area, and these are highly convoluted, so which will helps in increasing the surface area, so that it will in turn helps in reabsorption the water and the solids. The next one is the loop of Henle, and it has two limbs. That's the descending limb, which leaves the cortex and dips into the medulla. The second one is the ascending limb, which will ascend from the medulla and returns back to the cortex. So the descending limb has very thin segment, and the descending limb will have the thin segment, and ascending limb will have both thin and thick segments. The next one is the distal convoluted tubule, which is found in the renal cortex. This is less convoluted than the proximal convoluted tubule, and this one is very shorter in length. Next, we'll see the collecting duct. This collecting ducts will extend from the cortex and goes into the medulla, where it will open up into the renal pelvis. So this collecting duct's role is it will drain multiple nephrons into the renal pelvis. Now we have seen the anatomy of the renal tubules. Now we'll see the basic histology of the renal tubules. So as we all know that renal tubule has many parts like the proximal convoluted tubule, Henle's loop, and distal convoluted tubule, and collecting duct. So each of these parts will be lined by some kind of epithelial cell. For example, the proximal convoluted tubule will be lined by simple cuboidal epithelial cells, and which will also have the brush borders. So what is a special feature of this? Special feature here is these cuboidal cells will have brush borders, that is having microvilli. So the whole tube will having these microvilli, and it will encroach each other, so that lumen size will be very much narrow. What is the advantage of this? The advantage here is it will reabsorb most of the solutes, water, as well as the glucose, amino acids, and these are also having mitochondria, so which helps in active transport of the ions. So the function of the PCT is majority of the reabsorption. So almost up to 70% are reabsorbed in convoluted tubule. Next, the descending limb. It is lined by simple squamous epithelial cells, and the special feature is here the thin descending limb is very much permissible to water. So here the water reabsorption takes place. And the ascending limb. The ascending limb, as I said earlier, it has two parts. One is the thin ascending limb, and the next one is the thick ascending limb. So the thin part, like the descending limb, is also lined by simple squamous epithelium, but here it is impermeable to water. So here the only function happens is sodium chloride diffusion. And the next is thick ascending limb. It is lined by simple cuboidal epithelium, and it has a special features like it is helps in the sodium transport. So this functions as an active ion transport, but it is less compared to that of proximal convoluted tubule. Then DCT, distal convoluted tubule. The distal convoluted tubule is lined by simple cuboidal epithelium. It also has microvilli, but compared to that of proximal convoluted tubule, the distal convoluted tubule will have very few microvilli, and because of this, the lumen will be large compared to that of PCT. And what's the function of the DCT? DCT helps in fine tuning the ion. So here, what they'll do is basically they adjust the ions so that there will be normal balance, ion balance inside our body. And next is the collecting duct. So here it is lined by simple cuboidal epithelium or columnar epithelium. The special feature here is it is having intercalated cells. So the major function of the collecting duct is it is helps in the final water balance, and this final water balance is regulated by ADH, the diuretic hormone. Now let's come to the topic problem: tubulointerstitial diseases. So the diseases of the tubule, we are seeing learning about tubulointerstitial diseases because our topic is acute tubular injury, right? So here we should remember one thing: the diseases of tubules, which not only affects the tubule alone, it affects the interstitium too, and hence they are collectively referred as tubulointerstitial diseases. These are of two types. One is acute tubular injury, which is resulting due to either ischemia or toxic injuries. The next one is tubulointerstitial nephritis, which is resulting due to inflammation. Itis, nephritis means there is some kind of inflammation in the nephron. And here, the tubulointerstitial nephritis is either due to inflammation due to the infective etiology or etiology. We'll see that in detail. As we see in the previous slide, tubulointerstitial diseases is due to one, ischemia or toxic injury. Second is due to inflammation. So if it is due to inflammation, we'll call it as tubulointerstitial disease. If it is due to toxic injury or ischemia, we'll call it as acute tubular injury or necrosis. So in inflammation, if the inflammation is due to infection, we'll term it as nephritis. And if the inflammation is due to some heavy metals, like the toxins, drugs, heavy metals, or metabolic diseases like the urine nephropathy. This also causes inflammation that will also result in tubulointerstitial nephritis. And then anything which obstructs the tubules. So it may be due to neoplasm and some immunological conditions which will evoke the inflammatory response. For example, it's common one here is the sarcoidosis. And if we don't know the cause for this one, then we'll term that as idiopathic. Idiopathic tubular interstitial nephritis. So now we'll see about the acute tubular necrosis or injury. Nowadays, we are not using the term necrosis. Why? We'll see about that in the following slides. So first, is this a clinical diagnosis or a pathological diagnosis? Actually, it is a clinical pathological entity. So this is characterized by acute renal failure with or without morphological evidence of injury to the tubules. So here we may see the necrosis, we may or may not see the necrosis. We may or may not see the necrosis. So the necrosis may or may not be present, and hence the earlier term acute tubular necrosis is now replaced by acute tubular injury. So coming to the acute tubular injury classification. The acute tubular injury is further classified as the etiology into two types. First is ischemic type of acute tubular injury. Second one is the toxic type of acute tubular injury. So now we'll see in detail about the causes of ischemic tubular injury and toxic acute tubular injury. So ischemic acute tubular injury, first and foremost, the most common cause for ischemic acute tubular injury is decrease in the circulating blood volume. Either due to it may be due to any shock conditions, like for example in the hypovolemic shock, in the septic shock, or in the cardiogenic shock, maybe any type of shock. Whenever there is decrease in the blood circulating blood volume, so the blood to the renal organ is impaired, it will ultimately result in ischemic acute tubular injury. And then anything which involve the renal blood vessels, for example, microscopic polyangiitis or hemolytic uremic syndrome or TTP. So these conditions will affect the renal blood vessels. So this also will ultimately leads to ischemic acute tubular injury. Now coming to the toxic acute tubular injury or necrosis. This could be due to endogenous toxins or exogenous toxins. So in the endogenous toxins like the myoglobin and hemoglobin. So the myoglobin, there is a muscle injury. So the injured muscle will release the myoglobin and it will go into the kidney and it affects the renal tubules. And hemoglobin, in the same way, hemoglobin will also affect the renal tubules. And in the exogenous one, mostly due to drugs. For example, amphotericin B or amikacin. These drug-induced toxic tubular injuries, whenever you remove the drug, the offending agent, it will reverse back to the normal tubular states. And then we use dyes, we use contrast dyes in radiological studies. Those contrast dyes also will result in toxic acute tubular injury and sometimes organic solvents. You might wonder why these things affect only the tubules, why the tubules are more prone to the injury. That is because the proximal convoluted tubule, as I said earlier, this has more convoluted in order to increase the surface area so that it can reabsorb as much as it can. So this advantage is also a disadvantage in case of ischemia and of toxic injuries. So the proximal convoluted tubule has increased surface area for reabsorption and has very active transport system for ions and organic acids. So these results in high rate of metabolism and thereby it also has high oxygen demand. So it consumes more amount of oxygen. So in case of ischemia, this will be the first part which get affected. And so because of this high oxygen consumption, they are sensitive to ischemia and vulnerable. And the high metabolic rate, they are vulnerable to toxins. So coming to the pathogenesis form of acute tubular injury. So here you should keep two important things. First, the pathogenesis can either because of direct tubular injury or due to disturbances in the blood flow. Means either the toxin directly affects the tubules or something which disrupts the blood flow, either due to shock or some kind of vascular abnormalities. So first, ischemia or toxin. In this acute tubular injury may be due to ischemia or maybe due to toxin. What they'll do is first, there will be sublethal endothelial injury. So when this sublethal endothelial injury happens, ultimately they will release endothelin. This endothelin is a vasoconstrictor. Once there is vasoconstriction, then there is decrease in the blood flow. So this decrease in the blood flow which will result in reduced GFR, is glomerular filtration rate. So if the GFR is reduced, it will result in oliguria or anemia. Next one. So here the tubular epithelial cells are injured. What type of injury it is? Is it a reversible one or an irreversible one? So whenever there is an injury, see all know inflammation. Any injurious stimuli can evoke inflammation. So what they'll do? Naturally, they will express cytokines and adhesion molecules. So what these cytokines and adhesion molecules will do? They in turn recruit inflammatory cells. This will result in inflammation and injury. And then, so now coming to this one, tubular epithelial injury. If it is a reversible one, what will happen? So there will be redistribution of the brain protein. So this will result in the loss of polarity and the abnormal ion transport. So this abnormal ion transport will result in the symptoms. Okay, for example, there will be increased sodium, the distal tubules. Mostly the sodium will be reabsorbed prior to the distal tubules. So here there will be increased sodium, the distal tubules. What they'll do? They will give a tubuloglomerular feedback. So whenever there is decreased amount of sodium, which will give the renin-angiotensin system. So the renin-angiotensin system will be activated. This will result in vasoconstriction. So this will in turn causes decrease in the blood flow. So that's a decrease in the renal blood flow, which results in reduced GFR. Then the reduced GFR results in oliguria and anemia. So in the reversible tubular epithelial injury, the epithelial cells will detach from the basement membrane. It will shed off. So where they'll go? They will to the tubular lumen and they will cause obstruction. So the lumen will filled with the shed out epithelial cells and which will cause obstruction This will result in increase in the intratubular pressure. Once there is increase in intratubular pressure, which will directly reduces the glomerular filtration rate. Now, if the tubular epithelial injury is irreversible, what will happen? It's an irreversible, cells will die. So the death of the epithelial cells. Once the cell is dead, ultimately it will fall off from the basement membrane. So there will be any attachment, so it will shed it off. So it will shed it to the lumen. Again, they will cause tubular obstruction and they will increase the intertubular pressure and results in reduced GFR and albumin. Sometimes this death of cells will cause backlink. So once there is a backlink, then there will be decrease in the blood flow as well as increase in the interstitial edema. So backlink will cause the fluid escaping into the interstitium. So there will be interstitial edema and there will be increase in the tubular blood flow. Decrease in the tubular blood flow. Tubular flow. So once there is a tubular flow decrease, so there will be decrease in the glomerular filtration rate, and which results in oliguria. So the tubular backflow will also cause interstitial edema. This interstitial edema results in increase in interstitial pressure. When the interstitial pressure increases, it further damages the tubule. So this will also result in reduced GFR and there will be decrease in the urine output. So the patient will present with oliguria or anuria. So once again, I'll explain the pathogenesis. So here, the acute tubular injury, say the due to ischemia toxin, will have two things. First one is the sublethal and endothelial injury. So here, the sublethal endothelial injury results in the production of the endothelium, which is a vasoconstrictor. This vasoconstrictor endothelium will result in vasoconstriction. The vasoconstriction of the glomerular vessels will result in the reduced GFR, and this will ultimately result in oliguria and tubular epithelial injury. So here, the tubular epithelial injury. So whenever there is an injury, it will ultimately activate the inflammatory process. So it will express cytokines and adhesion molecules. So these cytokines and adhesion molecules will result in the acutment of inflammatory cells, and the inflammation will go on and will cause injury. The tubular epithelial cell injury, it may be reversible or irreversible. So in the reversible epithelial injury, tubular epithelial injury, first one is redistribution of the membrane protein. So when there is a redistribution of the membrane proteins, it will lose its polarity. So there will be abnormal ion transport, which will result in increased sodium in the distal tubule. Once there is increased sodium in the distal tubule, it will produce the tubulo-glomerular feedback. Since this tubulo-glomerular feedback will stimulate renin-angiotensin system. Once it is stimulated, it will result in vasoconstriction, decreased GFR, decreased urine output. So in the reversible epithelial injury, some epithelial cells will detach from the basement membrane and will end up in the tubular lumen and cause obstruction. These obstruction will result in intratubular pressure, increase in the intratubular pressure. Once there is increase in the intratubular pressure, it should result in reduced GFR and urea. And in case of irreversible tubular epithelial injury, there is death of cells. These death of cells will cause obstruction, tubular obstruction, increase in the intratubular pressure and reduce the GFR. And they also cause tubular back leak and decrease in the tubular flow and reduce the GFR. They will cause interstitial edema, increase in the interstitial pressure, which will result in the damage of more tubules and reducing the GFR. So they all ultimately results in oliguria. Okay, now we learned about the pathogenesis, the tubular interstitial injury. Now we'll see about the laboratory investigation. Okay, the patient now presents with decreased urine output. Okay, and you are that too after taking certain antibiotics. So now you are suspecting some tubular injury happened in this patient. How will you confirm it? We'll do some basic laboratory investigations. First is you want to know whether the GFR is reduced or not. So we'll check that. So whether there is increased creatinine values, blood urea nitrogen values. So we'll check for decreased GFR, elevated creatinine, and blood urea nitrogen. And then urine analysis. In the urine analysis, there will be muddy brown gas. Why there is muddy brown gas? Because the cells are shaded out. It will form into drugs. So it will accumulate into the tubules. Once it is passed in the urine, it will have that muddy brown cast. Renal tubular epithelial cells will also be present in the urine analysis, urine microscopy. And then next one is the fractional excretion of sodium. Usually will be more than 2%, while pre-renal diseases has the values of less than 1%. Next, the sodium. It will be usually more than 40 to 50 milliequals per liter. Acidemia, hyperkalemia. So in case of active acute tubular injury, then there will be hyperkalemia and metabolic acidosis. Why there is metabolic acidosis? Because there is some ion disturbances. So there will be metabolic acidosis. The hydrogen ions are not secreted into the urine. And possibly myoglobinuria or hemoglobinuria. So in case of muscle injury, then there will be hemoglobinuria. In case of any hemolytic condition, then there will be hemoglobinuria. Coming to the next part, morphology. So, as I said earlier, we will not necessarily have morphological changes in case of acute tubular injury. Okay. So once if we have the changes, what all changes will be seen? First, will be patchy necrosis in case of ischemic type of acute tubular injury. And in case of a diffuse necrosis in toxic type of acute tubular injury. So in this image, if you see these pink color painted things are patchy necrotic area, which are followed by normal appearing areas. These normal areas will later help in healing the necrotic areas. Okay, will result in the regain of the normal functions of the tubules. Okay, once the offending agent is removed, once the causative agent is removed. So this is helps in the recovery if the causative agent is removed. And the proliferative and differentiating potential of this helps in the healing process. And in case of a toxic type of injury, it will affect the whole of the proximal convoluted tubule, some part of the distal convoluted tubules also. Microscopy will see tubulobrexis, that is the rupture of the basement membrane, and the cells, glial cells will shed out into the tubular lumen. The lumen of the distal tubules will be filled with gas. So if you see the microscope, you'll see the gas. And there will be edema and inflammatory cells in the interstitium. We all know why there is edema and inflammatory cells in the interstitium. So here in this image, we see there is shelter of the epithelial cells and there is filled this lumen of the tubular epithelial cells is filled with the cells. Okay, lumen of the tubular tubule is filled with the epithelial cells. And here we can see the detached tubular epithelial cells. Next picture, you can easily see the detached epithelial cells. So now you can see the clinical features. Clinical features. So it has three phases. This acute tubular injury or necrosis has three phases. One is the initiation phase. Second is the maintenance phase. Final is the recovery phase. So in the initiation phase, it happens after the 36 hours. Here, the patient will have decreased urine output. Usually, it will be less than 400 ml urine, and that will be increase in the blood urea nitrogen. And then maintenance phase. Here, the patient will have polyuria. There will be increase in the blood urea nitrogen level, and there will be salt and water overload. Where there is salt and water, we have seen it before. There is a decrease in the urine output, so there will be increase in the salt and water overload, and there will be hyperkalemia. Why there is hyperkalemia? Because the iron exchange is not happening properly. So the potassium as well as the hydrogen ions are not secreted into the urine. So here there will be hyperkalemia and metabolic acidosis. Whatever hydrogen ion which has to be secreted into the urine, which is not secreted, so there will be accumulation of the hydrogen ion. Metabolic acidosis. Then, if the offending agents are removed, example, the patient is treated with amikacin. If you stop the antibiotic, then there is a high chance of patient's recovery. And in recovery phase, there will be steady increase in the urine output. This steady increase in the urine output will also result in the large amount of sodium potassium loss as well as hypokalemia. And in this phase, there is increased susceptibility to infections. So coming to the last part, prognosis. As I said earlier, the nephrotoxic type of tubular injury has better prognosis compared to that of ischemic type of acute tubular injury. Why? Because once you taken off the funding drug, then there is high chance of recovery. Prognosis also good. Whereas in case of ischemic type of acute tubular injury, particularly due to shock, if the shock is not corrected, there is high chance of mortality. To summarize, acute tubular injury is a part of tubulointerstitial disease. If the interstitial disease is due to inflammation, if it will be called as tubulointerstitial nephritis, if it only affects the tubules, then we will call this acute tubular injury. It may be due to toxin or may be due to ischemia. So the ischemic part is due to the decreased circulating blood volume and due to the obstruction of the blood vessels. And the toxic part is due to either endogenous toxins or exogenous toxins. Endogenous toxins, it may be due to myoglobin and exogenous due to drugs, dyes, or organic solvents. So, proximal conjunctive tubes are affected most. Why? Because it has the more amount of conjunctive area so that it has a more number of surface area to be absorbed. So, this will result in injury. Pathogenesis, all results in the decreasing GFR. Okay, so the decrease in GFR will result in IUD. Lab investigations. So first, biochemical investigations should be done with the levels of creatinine, deuterium, nitrogen. Then, renal tubular epithelial cells. Then, the urine analysis. Thank you.